Hey guys, this is Esquire from the forum, and here is the presentation on research that I made for you because I figured nobody wanted to read just like a gigantic wall of text. So here's a little presentation. Been doing this work over the last couple of weeks, and I will say that I started in a place of just simply taking the advice for granted and doing it. And now I've kind of come out on the other side also with some simple guidelines for myself. And so it started in simplicity, it ends in simplicity, but in the middle, we're going to dig into some of the complexity here. So I did a literature review. That is where you go through all the different literature, so lots of different studies, any other information you can get where it's maybe not a study but compiled information on a topic. So it's basically just saying you did a bunch of reading on the issue. So that's what I did. You're going to see big blocks of this text from studies and things that I've looked at. Go ahead and pause that if you want to get more into that information. I wanted you to have access to it because I have access to journal articles and things like this that most people don't. And I also want you to see how awful the shit I've been reading is. Like, this has been highly unpleasant reading. It really has been. So I have been looking for some specific things. I want to know what's really happening here in the body. And I wanted to know that just because it was made very evident on the forum that the mechanism that we thought was kind of going on without thinking about it or looking into it anymore is not what's actually happening. So let's just go ahead and cover that. And then what is already studied about this? There are already studies about this. Like, what are the contexts for the studies? What are they looking for? Why are they studying it? So in here, I don't have a bunch of different studies on holotropic breathwork. I have a lot of studies on hyperventilation. And hyperventilation is studied in many different contexts. So we'll look at that. And then you wanted to look at whether or not a program that you're going to be on, say if you are going to do this for 30 minutes, every week for a whole year, is that likely to cause long-term brain damage? Or how likely is it to cause brain damage if you're doing it for 90 minutes, 2 hours, 4 hours, whatever? You want these questions answered in terms of the dosage, like how much of this can you do before there's a problem? And we look at things like that in the public health field. We talk about, in epidemiology, we talk about odds ratio. So that's the odds of the probability that an event will occur to the probability that it will not occur. Or things like a risk ratio is the ratio of the probability that a disease event, say brain damage, is going to happen in an exposed group, say people who've done holotropic breathing, and to the probability that the disease event, brain damage, will occur in unexposed, so people who have not done holotropic breath work. So in a perfect world, we would know if we could just proceed with the program that was recommended and just do this, and we would know what our risk is that we're getting involved with, right? If we can answer these questions. So I sought out trying to answer these questions in my research. I did kind of start with what this is. Like, are we hyperventilating? My first reaction was that we were not hyperventilating because that breathing pattern is not really what you see when somebody is having a panic attack or some other situation in which hyperventilation occurs. So I was wrong. It is hyperventilation. It is hyperventilation because that results in lowered carbon dioxide level. And it does. It does result in lowered carbon dioxide level, and that makes it hyperventilation by definition. So we can just blow right past that. Here are measures. So these are things that I came across in my research, ways of talking about the quantity of carbon dioxide is in partial pressure. Partial pressure means that instead of trying to count all the molecules, you're quantifying the amount of carbon dioxide or oxygen with how much pressure is being created by them. So there's partial pressure carbon dioxide, then there's partial pressure of transcutaneous carbon dioxide through the skin, and then end-tidal carbon dioxide, that's the pressure of CO2 at the end of exhalation. SpO2 is a way to measure blood oxygen level, and this is what kicked this whole research project off with a forum member concerned about this being lower than 100. And My research does not talk about oxygen levels. This way is really researching carbon dioxide levels because of looking up hyperventilation and alkalosis and hypocapnia. So I don't have information that can relate directly back to this person's concern about SpO2. I also personally don't have a way to measure my partial pressure carbon dioxide while I'm doing this. So that is a barrier to our research that maybe we're trying to join ourselves and trying to figure this out for ourselves. That's definitely a barrier. I also saw in my research that people would write about severe hypocapnia or prolonged hyperventilation as being problems, but severe hypocapnia wasn't always defined by the same number or at all about what they meant by severe, and prolonged was definitely not quantified specifically. So I don't know if 4 hours of hyperventilation is considered prolonged in a world where, people were doing hyperventilation for many days because they were being hyperventilated by a machine. I think that that's very relative, and it wasn't quantified. That got thrown around in a few different instances, and I could not say exactly what that means. So I don't know how long prolonged hyperventilation is. And that's a barrier to using some of those studies to know whether or not the number of hours that were recommended to us in Leo's video, if those were a safe number of hours. I couldn't use that information in that way. Barrier to my research. So very quickly, we'll touch on the fact that shamanic breathing, it does not have some of the stuff that holotropic breathing does. So there's facilitation and maybe some touching and music and things. This is a part of a program, right? And I don't know what else there could be in that program that's different from what, say, we're doing if we're doing the shamanic breathing as recommended by Leo. So there's that. There's that to take into consideration, is that you're really kind of talking about two different things. Shamanic breathing is really just very simply this over breathing, quote unquote. So let's go ahead and look at all that stuff that's happening in the body. Okay, so it starts with a strong respiratory stimulus. That's the over breathing, the hyperventilation. This leads to the respiratory system removing more carbon dioxide than is metabolically produced in the tissues. So you're getting rid of more carbon dioxide than you normally would be. So that means lower blood CO2 level. And that means that there's an increased ratio of the bicarbonate concentration to the CO2 level. So the bicarbonate concentration is staying the same, and then your CO2 level's going down. That means the ratio is increasing. There's even more bicarbonate in comparison to the level of CO2 in terms of, say, percentages. And that leads to alkalosis. That is alkalosis. So here are some of the symptoms of alkalosis, or your pH of your blood turning more alkaline or more of a base as opposed to the acid end of the spectrum. So those symptoms of alkalosis include things that we are now familiar with and have experienced firsthand. So confusion, hand tremors, lightheadedness, muscle twitching, nausea, numbness or tingling in the face, hands, or feet, that pins and needles feeling we've talked about, and then prolonged muscle spasms. Here's a graphic representation of these different elements going on, these different mechanisms, and I want to kind of draw your attention over to the right. There's a box that says decreased oxygen delivery and increased oxygen consumption. I found that very interesting. I kind of can't wrap my head around what it means by increased oxygen consumption, so I just went forward looking at that. It's like, is it possible that even though this is a whole process is causing vasoconstriction, so this alkalosis and this lowered carbon dioxide in the blood is causing vasoconstriction, meaning that all the little tubes in your body are tightening up and the blood's not moving as quickly, as much as it would otherwise. And because blood carries oxygen to your tissues, this would seem kind of intuitively mean that there's less oxygen getting to your tissues. And then over here I see something like increased oxygen consumption. So in my mind, I'm always keeping the idea that systems are complicated, and that just because oxygen is in the blood and there's less blood moving around, that doesn't necessarily mean the tissues are not taking up as much oxygen. I'm just saying that for now, that I kept that in mind, that could be a complication in the system that you weren't expecting. But I don't know right now. Let's say we don't know, so let's go forward. Hypoxia is another part of this whole thing, which is oxygen deficiency in the body tissues. That's the whole thing we're concerned about, right? And that's what it's called. So there's a quotation here that says there is no clear evidence that hypocapnia, or decreased carbon dioxide, would cause irreversible changes unless it is associated with hypoxia, or a deficiency of oxygen, or severe organic diseases. So let's keep in mind that really what we're all scared of at this point is the hypoxia. We're actually concerned more about just oxygen not being in the tissues. And because we're concerned about oxygen not being in the tissues, we're concerned about the cerebral blood flow, right? We're concerned about whether the blood is getting that oxygen to our tissues or not. I love The Shining. Well, at least the trailer. It's my favorite trailer. So oxygen saturation, let's talk about that. That's really what's on everybody's mind. So cerebral hemodynamic measurement has shown that within 20 to 30 seconds of voluntary hyperventilation, blood flow velocity decreases. That means the blood flow speed is going down in the cerebral arteries, along with an increase in the capillary pH, PO2, and oxygen saturation. So what's the deal with this increase in oxygen saturation? What's up with that? So again, I'm finding these things that are saying the words like increased oxygen saturation. Why? That makes no sense. But here, for example, this is saying that's within 20 to 30 seconds. So maybe 20, 30 seconds, just a couple of deep breaths. And so maybe just after a couple of deep breaths, you have an increase in oxygen saturation. Does that mean that if you continue on hyperventilating for longer, that will continue? Probably not. It seems like it won't. But that's why these single sentences, you got to put it into a bigger context. So here is some information, read it at your leisure, about basically the idea that it's not 100% clear to at least the people doing this study and writing up this information that the decrease in carbon dioxide will necessitate restricted and decreased cerebral blood flow. That maybe that's not necessarily the case, and they're looking at this extracellular fluid in the brain, so the fluid in between the little cells in the brain, that's a mediator also, is what they're suggesting in this study. So they're saying, wait a minute, maybe just decreased carbon dioxide doesn't necessarily mean that there's decreased cerebral blood flow all the time. And what are the different mechanisms playing out? How are these different things interacting with each other in different situations? So this is getting more into the nitty-gritty, the technicalities of what happens. So reverse cerebral steal, or reverse Robin Hood syndrome. This is one of the ways that maybe it's not as simple as it seems. So right now, where are we at? We are at the idea that there is a lowered carbon dioxide in the blood and alkalosis going on, and this is causing vasoconstriction in the brain, meaning that there's blood is not flowing in the brain all over it, and that means oxygen is not getting to everywhere in the brain, or at all. Maybe. That's where we're at right now. Here's an idea that further complicates matters, is people studying brain injuries. They've played around with hyperventilation, and they're trying to see if perhaps that hypocapnia, that lowered carbon dioxide, and the alkalosis might cause the blood flow to actually increase to parts of the brain that previously were not getting enough oxygen and enough blood. And we're just taking that away from other parts of the brain. So there's like this homeostasis going on of the same amount of blood is happening in the brain, it's just going to different parts, stealing from the rich and giving to the poor, basically. So this is a syndrome that has been studied and has been posited as this possibility as well. But then you have this other study that just says, no, that's bullshit. That's not what happens. This one says that hypocapnia does not appear to reduce inverse steal or the Robin Hood effect. And it says, in fact, that injured areas may have increased CO2 responsiveness, raising the possibility that hypocapnia may aggravate secondary ischemic injury by diverting flow from the injured brain. So saying that no, that's not what's happening. That doesn't happen. And in fact, you are maybe irritating the damaged part of the brain through this process. That's what this study is saying. It also is saying that the hypocapnia may reduce the cerebral oxygen supply other ways besides even the alkalosis and the vasoconstriction that we've already talked about. Now it starts talking about how it is having an effect on the lungs as well, and that's another concern. So further bringing in some more complications here. Okay, so far we have looked at cerebral blood flow, and we've also looked at this kind of confusing oxygen saturation thing. So we're really very concerned about whether or not we're getting enough oxygen, right? And we've seen maybe some odd sentences about oxygen saturation increasing. And not really seeing what's going on here, because I do think we understand that we're getting less oxygen into the tissues in this process. So what's going on here? It's because offloading of oxygen from hemoglobin traveling in the blood into the tissues is really what matters. So your tissues need to actually get the oxygen. Just because the blood's flowing around and just because the blood has the oxygen, it doesn't mean that it's necessarily getting into the tissues where it actually does anything, right? So let's talk about that. That's gas exchange, that whole process. There's a good video from Crash Course. They put together these little animated videos to help people understand topics for their advanced placement tests in school here in the US. So I really like them, and I especially need to use them a lot for science. And they have a good video on gas exchange, so that's Crash Course, the respiratory system. So heat and CO2 activate the release of oxygen by lowering the hemoglobin's affinity for oxygen. So when your hemoglobin doesn't really have an affinity for oxygen, meaning it's just not quite the right shape for it, or what have you, it's encouraged to drop the oxygen off into the tissues where it does its job. And then you could say that heat is coming from exercise. So when you are exercising, say you're lifting weights and you're feeling the burn, all that heat in your muscles is going to make the hemoglobin drop off actually up to like 20% more oxygen for the tissues. So that's actually pretty significant. But not just heat, carbon dioxide also does this. So the way it does that is it binds to the hemoglobin, changing its shape. So the hemoglobin changes its shape to accommodate the carbon dioxide fitting onto it. And then that lowers its affinity for oxygen, because now its shape is not as conducive to the oxygen. And then the oxygen jumps off and more carbon dioxide can get on. It's basically carbon dioxide is commandeering the hemoglobin for its own purposes, making it not so amenable and suitable to oxygen, leaving it off in the tissues. Another element of gas exchange is that the spike in carbon dioxide will make your blood more acidic. And as we've discussed before, the opposite makes it more alkaline. That whole process is involved with the gas exchange as well. Carbon dioxide breaks down into carbonic acid, and so with less carbonic acid, the pH starts to rise. So this whole gas exchange process is important to understand, why your tissues aren't getting as much oxygen, and to make some of these sentences that otherwise just kind of seemed like they didn't make sense. It didn't fit into the picture. This really does kind of bring it all home. So this is a great thing to try to understand. And again, I do recommend that Crash Course video. It's pretty good. So here's the context out of which these studies are coming, because they're not coming out of people wanting to know if holotropic breathwork has satisfied customers with no brain damage, no problems down the road. That's not really where these studies are coming out of. They're coming out of studying hypocapnia, which is that decreased carbon dioxide in the blood, and hyperventilation, and those things in relationship to anxiety and panic disorders what happens to newborn little babies, anesthesia, how it can be used with anesthesia, heart rate and metabolic responses during exercise, shock therapy and seizures, and also brain and head injuries. So that's where these studies are coming from, the context from which they're coming, and there's always going to be all this conflicting information in these fields. There's scientists and people are really trying to kind of argue this out. So the procedure of voluntary hyperventilation has proven to be safe after medical screening for contraindicating conditions and has been demonstrated across numerous studies to be helpful in treatment of anxiety as a tool for diagnosis and desensitization. So these particular people are saying that voluntary hyperventilation is totally safe. It's been proven to be safe, no big deal. Already use it for panic disorders. And they're saying that's after screening for contraindicating conditions. That means that anything that would not mesh well with voluntary hyperventilation, and they know that ahead of time. So, hey, you already have this illness, you shouldn't be hyperventilating. So this study, these people are saying it's totally fine. Okay, let's move forward. Hypocapnia and panic disorders, you can read this, but the gist is that it's used to simulate people's experiences when they are having a panic disorder. So they are having a panic attack. They have a panic attack, and then this induces hyperventilation. So if you induce the hyperventilation, they're going to induce the panic as well. So these associated things, they're associated in the body. So this is to kind of make people have a panic attack and then start desensitizing them with a course of therapy and a whole program and process through which they're doing. It's also studied quite a bit in relationship to brain injury, hyperventilation, and hypocapnia. This is studied quite a lot when somebody has a brain injury for some other reason, using hypocapnia and hyperventilation as a treatment for that. So people are fighting back and forth about whether or not this is an appropriate treatment and under what circumstances it's appropriate, under what circumstances it does more harm than good. And like everything, it's complicated. It's more some people say here are the circumstances in which it's fine or really helpful or saves people's lives, and then here are some circumstances where it seems like that it causes more trouble. So this particular study is saying there's no evidence to suggest that hypocapnia improves outcome in acute brain injury. They're just saying nope, it has no value, and there are unfavorable outcomes at 3, 6, 12 months down the road. It's totally a problem. I will point out down here that it says especially after 60 hours of hyperventilation. I mean, like, that's kind of the level of time we're talking about. These people are on ventilators, and the ventilator is hyperventilating them. So they don't have to be, strong and badass enough to make themselves hyperventilate that long. You can just have a machine hyperventilate somebody for 60 hours. So I will point out that people thought that it's okay to go ahead and hyperventilate somebody for 60 hours in the pursuit of more information on this topic and to possibly help them. Now here's a slide that says the complete opposite. So it says hypocapnia, even when marked, is severe, I guess you could say, or notable, is normally well tolerated. Transient induction of hypocapnia can lead to life-saving physiologic changes in patients with severe intracranial hypertension or neonatal pulmonary artery hypertension. So this is saying that it does have a place, and it has been helpful when there are issues with the brain and in the cranium. It's used to relieve pressure. And it's used to alleviate some pooling of fluids. These are primarily why it's used, because vasoconstriction in that sense is helpful to stop there from being so much fluid, and also to limit the mass of the brain inside the cranium. So an effect on little baby brains, though, is not good. And so that warning that if you're pregnant is a good one. Don't do it if you're pregnant. Basically, a baby's vascular structure is just not developed enough to handle this. So that's really the issue going on. So not for little babies, and don't do it while you're pregnant. So here's hypocapnia and anesthesia. This is studied quite a bit. Anesthesiologists use this to basically still keep people asleep in some cases, and they can also be used as a potentiator for opiates, so making these opiates work better, better, faster, stronger, whatever. But here are two different opinions on the use of hypocapnia and anesthesia. This one says that it is associated with an increase in postoperative mortality rate and LOS, or length of stay in the hospital. This is saying that if it's associated, if you have this low carbon dioxide level during anesthesia, that there is an increase in the chances that you will die after surgery, and that your length of stay in the hospital will be longer if you don't die. Versus this other study, these other writers who are saying that hyperventilation is still applied during some types of surgery performed under general anesthesia, but when injudiciously applied is detrimental, yet when applied appropriately is useful addition to the anesthesiologist's toolbox, is basically what that pedantic language is trying to say. So here are two different opinions. One saying it's so important to not make sure it doesn't happen. Another one saying, there are times when it can be judiciously applied and that it will have benefit. So a big question we all have, I think, is how long can you do this for? If you do it longer, is it worse? What time frame is really pushing your luck? I think is something we want to know. So let's talk about at least what I've found. I didn't find clear answers to my questions. I'm not going to pretend that I did, but I can show you what I found. So this is a chart talking about the panic disorder studies. So I will draw your attention to the column that says test duration, if you can see it. I think the longest one there is 3 minutes. So while we're talking about use of hyperventilation and inducing hypocapnia during these studies, and saying that it's totally fine in these studies done for anxiety disorders and panic disorders, I will show that the longest one I see on here is that they were only doing it for 3 minutes. And so that's really not analogous, or maybe even useful at all, to when we talk about doing this for 30 minutes regularly, or 3 hours once in a while. I mean, it's really not the same amount of time. So if the dosage is really kind of the question, how much hypocapnia is good versus bad for you, we're only talking about 3 minutes for the panic disorder ones, so that might not really be useful to us. This one was really interesting. I'm going to go ahead and just read it to you. In order to eliminate general anesthesia paralysis and passive ventilation as factors in their study, is what they mean by eliminating it. Cerebral blood flow was measured before, during, and after hyperventilation in 4 experiments in fully conscious, healthy men. In each study, cerebral blood flow fell with the onset of hyperventilation and gradually rose as hyperventilation continued, and exceeded control levels when ventilation returned toward normal. Okay. The carbon dioxide level fell initially, remained constantly low during hyperventilation, and returned toward control, or their baseline, when hyperventilation ended. So look at the little chart on the left where it says % change of CBF, that's cerebral blood flow. So you'll see that the cerebral blood flow immediately goes down, pretty far down, and it looks like it's at about the half-hour mark is when it reaches its nadir, like its lowest point. And then it starts coming back up. And you'll see that in this, it goes until 4-hour mark is how long this hyperventilation is occurring. And then after that 4-hour mark, when it's not happening anymore, the hyperventilation's over, then all of a sudden the the cerebral blood flow really spikes, really goes back up to well above normal levels. So that I thought was really interesting, because I think it was really kind of easy to assume in a misleading way that if your carbon dioxide is lowered after doing this for, say 15 minutes, then it's only going to just keep going down. It's going to keep going down, and it's going to keep going down at the same rate, or maybe even spike downward at some point. And really, like, you can't just make predictions like that just because it sounds like that makes sense. So it's not like your carbon dioxide level is just going to go down until what it eventually reaches zero and then you die, or what could that possibly look like? Well, it turns out this is what it looks like. Is it kind of goes down and spikes downward at about, looks like the 30-minute mark, and then it starts rising back up over the course of the next 4 hours, which is a much longer study time than I thought they would do on somebody. Especially, it doesn't seem like they had somebody like ventilating them. I don't think it was on a machine. I think they might have been doing it like in a holotropic breathwork shot, but I'm not 100% sure on that. So here's another excerpt that includes some time of hyperventilating. I'll go ahead and read it to you. This one was particularly interesting as well. Gordon and Rosanda report the only large series of patients treated with prolonged hyperventilation. Their work is a retrospective evaluation of 251 patients with severe head trauma, 51 of whom were hyperventilated, from between 6 hours to 41 days, with a mean of 10 days. 10 days. So they were being hyperventilated by a machine. Few details of their case selection are given, but they found a reduction in mortality from 32.8% to 9.8%. That's a huge reduction in mortality. Mortality means death, by the way. The number of surviving patients with severe neurological conditions caused by this previous problem increased substantially in the treated group. So the people who were receiving this hyperventilation, the number of them that continued with brain problems afterwards were increased. But the percentage recovering completely did not differ in the two groups. So what that means is that you have these two groups. One of them were hyperventilated, one of them was not. But they both had head trauma. The group that was hyperventilated and the group that was not hyperventilated, the percentage of them who recovered at all and recovered completely is the same. But the ones in the hyperventilated group, they had people who were surviving with these kind of ongoing head and brain problems afterwards. But they also had fewer people die. So it makes sense that maybe the people that would have otherwise had died, like they had some really serious trauma going on that should have perhaps resulted in death. They got to keep on living, but as a result of that, they had some conditions and issues going on after that. So that's something to take into consideration. This is really quite remarkable that a lot of people apparently were saved really by this after they had head injury. This says one must question both the social utility and specific effectiveness of hyperventilation in this study, particularly since most patients with severe head injury hyperventilate spontaneously anyway. I really don't understand why you would question the social utility of something like this if that mortality rate is so much lower. And I'm not really understanding the conclusion to this paragraph and what they're getting at, but I figured I would go ahead and share this with you. I thought this was particularly interesting study, and it shows some time, which is really good to see, that it's 6 hours to 41 days with a mean of 10 days. So now we kind of know what lengths we're talking about here when people study hyperventilation, how long they're making people do it for. This is an interesting discussion on chronic hypocapnia because we're talking about time. So we're talking about, maybe subjecting yourself to hypocapnia for maybe 30 minutes a week or 30 minutes a day for a week or what have you. This is talking about chronic, ongoing, really long-term hypocapnia. That's, some people just live with this. So this says many hyperventilating patients having hypocapnia do not have complaints or symptoms at all, and there is also no evidence this deviation would shorten the life. Being complaint-free in chronic hypocapnia is likely to be due to relatively regular respiration and moderate fluctuation in carbon dioxide level, since the symptom-causing effects of the breathing pattern significantly depend on the degree of breathing irregularity. So I believe what this is getting at is that it's not totally constant. It's not this really consistent thing where their body can never adapt and get back to what would be considered baseline levels. Then that's why they don't necessarily have a lot of complaints about their health with regard to the hypocapnia. Now, people not complaining about problems in their health is really quite meaningless. People can live and adapt to all kinds of crazy things and think that nothing is wrong with them and think nothing is wrong with their body. So that self-reporting is really not all that reliable. But thinking about the fact that there are people who go around all the time, very regularly, with hypocapnia for other reasons besides making themselves hyperventilate for therapeutic purposes. The impairment of neurologic function is something that I would consider to be an important consideration going forward. I felt like this rang very true with my own personal experience, having tried the shamanic breathing, and it's going to inform how I proceed with this in the future. So I'll read a little bit of this to you. The potential for neurologic dysfunction, not damage or injury or whatever, just dysfunction, meaning that you're functioning a little bit different than you normally would, maybe a lot different. After hypocapnia is most clearly documented in post-operative patients, meaning it was done with anesthesia. Healthy patients subjected to hypocapnia have significantly impaired psychomotor function for up to 48 hours postoperatively, and such effects are more marked and occur with less severe hypocapnia in older patients. Let's see. So more profound intraoperative hypocapnia, even for a relatively short duration, can delay reaction times for up to 6 days. So I found this to be true. After I did this, I drove my car later that day after I did shamanic breathing, and I felt pretty spacey, and like my reaction time was definitely decreased. I absolutely noticed that. And so I would actually really recommend being careful about driving a car, anything like that, operating heavy machinery when you have done this. So I would wait. I mean, this is saying up to like 48 hours later, and maybe up to like 6 days later. So for that reason, I really can't justify doing this on a weekly basis because that leaves a lot of reaction time wanting. That's a lot of time to go with like a delayed reaction time and impaired psychomotor function. It really is. So if I did that every week, I could expect, most of my days of my life to have this like delayed reaction time and this functionality issue. So while I had a great experience doing shamanic breathing, I would personally not do it every week for that reason. So I found this very important. So, okay, we talked about all the confusing information, clear as mud about whether or not it's safe, but does it even work? Why are we even bothering talking about this? Here are some surveys and questionnaires and inventories, all the questions that you can get asked to see if there's any sort of improvement, if things that you might have been wanting, psychological improvement, right? So there's an inventory or a survey or whatever for everything nowadays. It's amazing. So here's some names of them. You can go look them up. You can take them. You can, do whatever with this if you want. But I think it's very interesting to have these questionnaires handy. I use questionnaires sometimes. Like I have a mindfulness skills questionnaire that I love to use to measure my progress. So it's something you guys might. So how could this work? Here's why maybe there's something to this and why it could actually do anything to you. I'll just read it to you. Given that the frontal lobes are involved in control and selective inhibition of cognition and behavior, both hypocapnia and low-dose anesthetics may cause a temporary weakening of the inhibitory action of the frontal lobes upon cognition and related subjective experience, resulting in disinhibition of previously avoided or suppressed internal stimuli. Thus, dissociation and disinhibition may facilitate experiential exposure to feared internal representations, meaning it is shutting down your gatekeeper. Like inside, you probably don't let yourself think about or experience whatever, like example, past trauma. And now it's shutting that inhibition down and it's experienced again. Here's some more information on basically that same concept, that it also functions like ketamine does in that regard, and it allows for a catharsis. And I know that in my experience doing this, I absolutely experienced a catharsis over the next couple of days that was noticeable and powerful. And I'm not sure if it's a placebo effect. I absolutely was expecting a cathartic experience, and that's what I got. So I did get it delayed. I was expecting it immediately after, and instead there was a delay, and it came up over the next couple of days. So there's a potential for placebo effect. I personally think that you can make the placebo effect work for you, and it doesn't matter how something works as long as it works and if it's safe. So all those things are something to consider. But this is kind of the mechanism by which this is allowing for past trauma to be healed. So talking about whether or not you're getting healed and your psychology is improving, we can talk about affect measures. So affect is, a way to talk about your attitude and like how you feel. Right? So negative affect is you're having a lot of negative experiences and negative feelings and you're showing it. Same with positive. So this says that participants received 2 holotropic breathwork sessions. This was actually about holotropic breathwork of approximately 3 to 4 hours length over the course of a week. At post-test, participants were found to show significant reductions in negative affect as measured by the positive and negative affect scale and significant reductions of psychiatric symptoms on the brief symptom inventory. That same study then went on to say that the positive affect that was, so much better had significantly lowered by the 6-month follow-up, and that's because there was just like this general reduction in arousal. And like generally speaking, these people were not having such strong or positive or negative affect. I could say they're more equanimous, perhaps, but that's what this is saying. I didn't read the study that this one's referring to, so I haven't read that entire study itself. Maybe something to look into because I'm curious what the long-term effects are about these positive affect measures. What's going on long-term in terms of like reducing positive affects. What does that mean? Is that something desirable? I personally would say that it is because I think equanimity is really what's the most desirable and kind of why we do a lot of this work. But yeah, that's definitely something to look into. So in summary, I don't know. I don't know if it's totally safe. I don't think anything is totally safe. There's risk associated with anything, but I will say that my questions meant to really quantify the amount of risk. I could not answer them. I absolutely could not answer them. Just going back to what I was looking for, do we answer these questions? Well, yeah, we know what specifically happened. We know why it's being studied and where it's being used. We kind of determined that it's not really safe to do for 30 minutes every week. I mean, it could be, but the translation of psychomotor dysfunction and delayed reaction time, which I absolutely felt through my direct experience, I think is potentially unsafe in other situations in your life. So if you drive a lot or otherwise handle heavy machinery, or you really need your psychomotor functions to work well so you don't get hurt because you do maybe more athletic or precarious things, then that might not be a great thing to do every week. There might be some consequences for that. How likely is it that 90 minutes or longer are going to cause long-term brain damage? It seemed like there were, worse outcomes for people with brain injuries when it was done for a really long time, to maybe 60 hours or so. So I don't know. It seems like nobody was really all that concerned about hyperventilating people for 90 minutes. They didn't think that was going to totally destroy their lives. It seemed like they did well more than 90 minutes in different studies. So that's something I can take into consideration, is that people who were trying to design these studies and figure out if it was helpful, they went well over 90 minutes, well over 90 minutes. So I think that potentially it could be safe for those longer stretches of time. But there were problems when it got to much longer periods, up to, like we discussed, up to like 60 hours. And I think that did have issues. I wasn't able to get an odds ratio. I wasn't able to get a risk ratio because these studies weren't set up to really answer these questions about like what is just the straight up risk factor just for shamanic breathing, instead of like mixing it up with a brain injury and mixing it up with anesthesia, mixing it up with all these other things. Leads me to just the concept of equipoise, which is the idea that people do studies like this, like the studies we've been talking about, because there's just this genuine um, genuine not knowing and disagreement among experts in the field. And that's why these studies have a place and are even being done, is that people are saying, look, we genuinely don't know if this course of treatment might be the best course of treatment. It might be, and we genuinely don't think that it's going to cause more harm than good based on what we know now. So to keep in mind that studies were conducted with this idea in mind. They thought that hyperventilation could be potentially useful in some of these situations, and even doing it for up to maybe 60 hours, they thought it could be useful in some of these situations, and that's why they even studied it in the first place. And that's why they can even ethically do that, because these things are being studied on human beings, and they have to take that medical ethical consideration very seriously. So in the end, Leo said that tens of thousands of people have done shamanic breathing without damage in workshops all over the world, and that is proof enough for me. This isn't rocket science. So in the end, Leo is saying that it's really a simple matter, that people already do this and they seem to be fine, and that's enough for me. I don't really need or want to know what's going on with all this other stuff. And that's understandable. I would say that smoking, I think, is a really good phenomenon to look at, because smoking was said not to harm anyone until the associations were made between smoking and and specific diseases. Those associations had to be teased out through experimentation and studies, and we don't always know what correlates with what until we really kind of look into the nitty-gritty details of things. Um, that being said, I think that there are way more dangerous things that we do all the time. I think that this was being studied for longer durations of time than was recommended to us by experts in the field, and they felt it appropriate to subject people to those length time hyperventilating. I think that there are people who do it and get a benefit from it, and there is not really an established association between people doing holotropic breathwork and having severe brain damage. Like, that association has not been established, and I'm not finding anything saying that. So I think that the mechanisms, if you only know the mechanisms about vasoconstriction and this reduced oxygen supply, if you only think about it in that way, it seems really scary. And I think that our desire to live kicks in and just steers us clear from any risk associated with that. I think we're all very scared of something happening to our brains. I think we're very identified with and attached to our brains, and it's going to be like the source of all of our success, right? So I think there's a lot of fear there. But I feel better knowing that I went through the whole process of really looking into this, so that I could come out on the other side and say in kind of simplistic terms that I don't know how safe it is in concrete terms, and I don't know exactly how much time is too much time, and I do know that I got some benefit out of it, and I do know that I'm willing to go ahead and do it again in the future because it doesn't seem to me to be something that is a huge risk. So, yeah, I think in the end, you can just kind of simplistically say that everybody should just kind of do it for themselves and gauge what their risk level is how safe, how comfortable they feel doing it, and that's just up to them. I mean, that's the simple answer. Like, it's up to you. It's up to you if you feel comfortable making any sort of risk that involves your brain for the benefit of your psychology. And that's a whole other can of worms of like, maybe you're super unhealthy and have all these other risk factors because you have psychological issues. Maybe your psychological issues and your past trauma are making you smoke cigarettes. Like, maybe you're using that to pacify yourself. So, what then is the health risk of doing this as long as it makes you quit smoking? I don't know. It's so complicated. I don't know. So that's the end. The end is a simple answer of I don't know, but I went through the complexity, and I'm way happier to be on this side of the complexity with this simplicity. So here are my references. Super casual. I didn't do a formal reference list. I'll go ahead and put some of these studies. I'll link them. I'll attach them so people can read those in their totality if they desire to. If you guys have questions or comments, go ahead and leave them. I really don't want to research this anymore. I'm so sick of it. So if you ask me a question and I don't know the answer, I'm just going to tell you I don't know, and then Godspeed, go look it up yourself. All right, guys. I'll talk to you soon. Bye.